Sean, if you don't mind, I'm just going to introduce you as well. I don't know why there's an echo. Let me just look quickly. If folks aren't talking, just go ahead and please mute yourselves. So we're very lucky to have Dr. Sean Falade to speak with us today about opioid use disorder. Dr. Falade is an associate professor in the Division of Infectious Diseases, and I can't say enough about how you have transformed care for both Hep C here at Johns Hopkins, and also for people with opioid use disorder and other substance use disorders. I personally have benefited so much from your expertise and all the programs you've initiated in the Bartlett Clinic, and my patients have as well. So I'm so grateful that you are here with your expertise, and I'm excited to hear this talk from you as well. Thank you for chatting with us today.
Thank you, Natasha, for the opportunity to speak and your very kind introduction. I am really excited to be here today to talk to the group about substance use disorders and mental health disorders. The problem we currently have in Bartlett, some initiatives that have tried to address some of those issues, and also get your input on next steps in improving substance use disorder and mental health disorder treatment as a way to optimize outcomes overall for our patients. And so I'm going to start by talking about what a substance use disorder is, because for some, I think there's still a perception that a substance use disorder is a bad decision that patients can just choose to stop making whenever they're ready. But the reality is that substance use disorders are treatable chronic medical diseases. They involve complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And what that translates to is that people with substance use disorders use substances or engage in behaviors that become compulsive, meaning that it's beyond their control. And these behaviors often continue despite harmful consequences. There are multiple substances, as you can see on the slide, that a patient can have a disorder to, but for the rest of this talk, I will focus on alcohol and opioids. And so some key points to keep in mind when you are providing care or working with a patient with a substance use disorder. They have abnormal functioning in brain circuits. And this abnormal functioning persists long after drug use has stopped, so that individuals with substance use disorders are prone to priming and kindling, meaning that if they are re-exposed to the substance, even after a period of abstinence, it can precipitate rapid resumption. We know that patients in recovery need to consistently be in recovery for at least 5 years for us to see a significant reduction in the risk of relapse. And there's individual vulnerability to a substance use disorder based on environment, exposure, and genetic factors. And when we think about Baltimore City and the structural issues we've had in Baltimore City for decades, it's, I think, really easy to see why our patients are so predisposed to substance use disorders through no fault of their own. Nationally, if you look at Americans, 19% of Americans report illicit drug use in the prime month. That's a lot, right? Almost 20% of Americans. 1.7% report injection route of administration. And we all know that we have increasing rates of opioid injection, which have led to increases in hepatitis B and C, 400% increase in incident hepatitis C amongst 18 to 29-year-olds, over 100% increase in incident hepatitis B in some areas. And we've also been privy to the injection drug-related HIV hotspots, most recently in Indiana and West Virginia. And as we bring this closer to home and think about Baltimore, where we have high HIV prevalence, high HIV incidence, and although we don't talk about it much, the reality is that almost 30% of prevalent HIV cases in Baltimore are attributable to injection drug use. And many of these patients continue to need care for their injection drug use to reduce the harms of drug use, to help them to engage in their HIV care, and to reduce the risk of HIV transmission to others. When we come even closer to home, to Bartlett, based on data from the Moore cohort, we know that 12% of our patients report heroin use in the prior 6 months, 5% other opioids, 14% cocaine, and 13% hazardous alcohol use. And in a subset of patients that got the computerized adaptive test for mental health, if you looked at the combined prevalence of mental health and substance use disorders, 46% of our patients have at least one mental health disorder or substance use disorder. And when you think about our Ryan White program, which strives to provide outstanding care to over 3,000 patients, that is a lot of patients with mental health and substance use disorders that need care. And as HIV providers, we have been so excited to have the opportunity to save our patients' lives by providing HIV care. And I would like you to focus on that plot to your left, which shows national opioid overdose related mortality. And that orange line going all the way up with no sign of coming down is opioid overdose related to synthetic opioids, which I think in many ways is similar to the plot to your right, which shows HIV mortality in the early phase of the epidemic in blue, which dropped significantly after we started using highly active antiretroviral therapy. And the question is, we could do this for HIV. Do we have the tools to reduce the harms of opioid use disorder? And the unequivocal answer to that question is yes. We have medications like buprenorphine and methadone, opioid agonist treatments, which we know consistently reduce the harms of drug use. Now, one of these mechanisms is by reducing the frequency of use. The plot to your left is clinical trial data looking at patients that were randomized to no treatment in the top cross hatches, or buprenorphine in the open diamonds, or methadone in the closed in circles. And what you see is that over time, patients who were randomized to buprenorphine or methadone have significant fewer days of opioid use per month compared to patients that did not get any treatment. The other thing I think is really important to notice is that majority of patients did not go from use to abstinence overnight. Most patients took up to 60 months to get close to abstinence. And so the expectation that we will start patients on treatment for their substance use disorders and they will immediately become abstinent, I think in many cases sets us up for disappointment and sets our patients up for failure. The other thing that I think is critical to know is that treatments like methadone and buprenorphine reduce the risk of incident infectious diseases like hepatitis C. This is a systematic review looking at the impact of methadone or buprenorphine on incident hepatitis C across multiple different countries. And you see that these treatments reduce incident hepatitis C by 50%. We know that patients with substance use disorders have a high prevalence of co-occurring mental health disorders. It's thus not surprising that mental health treatments also reduce the risk of drug use harms. When we think about the worst harm possible, the answer is death. And this is data on the left looking at heroin overdoses in Baltimore City in red. And you see that as the uptake of buprenorphine went up after legislation was passed in 2000, heroin overdoses went down significantly. Unfortunately, we have a new kid on the block, fentanyl. And so we need to double our efforts around making sure that people have access to buprenorphine for treatment. Another key point is that once a patient has had an overdose, they are at incremental risk of dying from their next overdose. And so the plot to your right looks at all-cause mortality amongst individuals who had had one overdose. And you see patients who got no medications for opioid use disorder treatment in the solid lines versus patients who got methadone, buprenorphine, or naltrexone. And you see a significant reduction in death in patients that got treatment versus those that did not. When we think about the impact of substance use on HIV outcomes, this bar graphs provide data in 593 HIV and hepatitis C co-infected patients. And we are looking specifically at proportion who missed greater than 50% of their HIV care appointments in the preceding years. It's not surprising that those who reported drug use in the prior 6 months had a significantly higher rate of missed appointments at 37% compared to those that did not report drug use. In very elegant work recently published by Kim, Chanda, Lau, Moore, Keruli et al., they looked at 279 patients who were initiated on buprenorphine in the Bartlett Clinic between 2002 and 2017, and compared viral suppression rates pre-bup to post-bup. And in the time-fixed model, you see that patients that were initiated on buprenorphine had a 14% increase in likelihood of viral suppression. And the longer they stayed on buprenorphine, the increased likelihood of viral suppression. Again, showing that buprenorphine has potential for improving HIV outcomes. Work done by Greg Lucas, published in Annals in 2010, had shown us the best way to get our patients connected to buprenorphine. In this trial, patients were randomized to buprenorphine in clinic in red or blue to referral offsite for buprenorphine in black. And if you focus on the first plot, you see that those that were referred to treatment in clinic had a much higher likelihood of receiving buprenorphine. They had a much lower likelihood of having a urine test that was positive for opioids. And they also had a much lower likelihood of having a urine test that was positive for cocaine. Very excitingly, patients that were in the clinic-based buprenorphine arm also had increased attendance at their HIV care appointments. And so I think without a doubt, we know buprenorphine has potential to help our patients. And the question that I ask myself, and I think would love for everyone on this call to ask themselves, is how could some of this work in my practice? And the answer is that it starts with screening. We will not know if our patients need help unless we ask them. There are tools like the NIDA drug screening tool, which just asks questions about use of alcohol, tobacco, prescription drugs for non-medical reasons, or illegal drugs. And a positive response to any of these questions should prompt further questioning about frequency of use and the amount of use. Now, personally, I found it very helpful to just use the tool in Epic. And so this is the tab that has allergies. So after I do allergies med review, I just go to history. And under social history, I ask about any alcohol use. If the answer is yes, then I'm prompted to ask about the number of drinks and the type of drink. I ask about substance use. If the answer is yes, then you're automatically prompted to ask about the types of drugs used and the frequency of use. Similarly, there are questions for tobacco use. And while many may think that addressing substance use disorders is this incredibly complex thing, the answer is surprisingly not. This is from the American Association for Addiction Medicine, and these are the guidelines for how you evaluate for substance use disorder. It's based largely on history provided by the patient and then a comprehensive assessment. In our history, we're asking about infectious diseases, acute trauma and pregnancy, alcohol and other substance use, including tobacco. The laboratory evaluation, we already do CBCs, LFTs, infectious disease testing. We need to get confirmatory urine drug testing and then assess for pregnancy. Social factors we know impact HIV outcomes and substance use outcomes. And so we want to understand issues around food insecurity, housing, transportation, domestic violence, and significant mental health issues, which is already part of our routine clinical care. I do think it's important to be able to distinguish a patient who just uses substances recreationally versus one who has an opioid use disorder. And so there are some criteria, and you need to have patients meet at least 2 or 3 of these criteria for them to be considered as having an opioid use disorder. They have to be taking the substance in larger amounts or over a longer period than intended, a persistent desire or unsuccessful efforts to cut down or control use, a great deal of time spent to obtain or recover from effects, craving, continued use despite persistent or recurrent social or interpersonal problems, important social, occupational, or recreational activities given up due to drug use, recurrent use in physically hazardous situations, continued use despite knowledge of recurrent physical or psychological problems, tolerance, and withdrawal. And I would say to you that if a patient has had one overdose, clearly that is an indication that this patient needs help. If a patient tells you that his family life is falling apart because of his substance use, that's an indication that this is a problem, a patient that needs help. And as we think about approaching substance use disorders, I know for many, it's sometimes a little challenging to bring up the discussion. And these are some points that, I have learned over the last couple of years. Shame and guilt are not helpful motivators. If anything, they make it more likely that our patients will not discuss these issues with us. We need to support patients to accept that substance use disorders is a medical problem, and also that it's something that they have to take ownership of responsibility to change. Our role as providers is to support them to be successful. The goal, while we want to see patients become abstinent, in many instances, early on in the phase of treatment, may need to be reduced use rather than abstinence. And we also need to understand that patients will move through the stages of change at different rates. Many patients remain in pre-contemplation and contemplation for many months, and you will have to bring this up multiple times before they move to the action phase where they're ready to take medications, and maintenance phase where they're ready to stay on medications for their substance use disorders. But relapse, unfortunately, is part of the disease, and so should be expected, and we should be prepared to provide ongoing care and supports for our patients, even if they relapse. And in practical terms, how does this work? So things as simple as, if you have a patient in whom you are concerned about their substance use, clearly stating the diagnosis. I am concerned about your use of heroin and its negative impact on your health. I am concerned about your alcohol use and its negative impact on your health. And very often, patients just look at me like, and so I ask, so what do you think about how worried I am about your heroin use and alcohol use? And very often I get a response ranging from, I'm not worried about it, why are you worried about it, to, I am so glad you asked. The next thing is, for patients that remain pre-contemplative, maybe providing some cues about why you're concerned. That could be, I'm really worried that you were in the emergency department for an overdose a month ago. I'm worried that the next time you may not survive the overdose. Or you shared with me that you really want to get a CDA license. I'm worried that your continued use may make it challenging for you to get the CDA license so you can become a long distance driver. Ask them what they know about treatment, discuss treatment options. And again, I think the most important thing is realizing that we cannot make our patients change. We can support them to be successful. And a way that has worked practically for me is always ending that discussion by asking the patient, what would you like to do regarding your heroin use? What would you like to do regarding your alcohol use? And again, making it clear that I'm there to support them and help them be successful. Destigmatizing substance use disorders is important. I remember as a resident hearing words like clean and dirty used all the time. We need to consider instead using words like currently using drugs or drinking, currently abstinent. How is your recovery journey going? How are you engaging in your recovery? And when we're talking about urine toxicology, using information-based results, your urine test showed buprenorphine, your urine test showed cocaine. There are multiple options for treating substance use disorders. And so we're all very familiar with methadone, which can be used as a tablet, oral solution. Patients have to take this daily. We have the most data for retention in treatment. We know it improves functioning, it reduces criminal activity, it reduces likelihood of incarceration and acquisition of HIV and hepatitis C. Now, unfortunately, it can only be administered in opioid treatment programs, and it has a high risk for respiratory depression. Now, one substance that we can use as part of our care in routine HIV care is buprenorphine, which is available as a sublingual tablet or film. I think it has the advantage of having a ceiling effect on respiratory depression, meaning that patients, the likelihood of death from buprenorphine overdose is almost essentially zero. Patients also have less euphoria, so the diversion is also less because there's less euphoria. It helps with social functioning, reduces incarceration, and reduces HIV and hepatitis C infection and transmission. Now, the only disadvantage is, unfortunately, it continues to require that providers get an X waiver to prescribe buprenorphine. So how does buprenorphine work? We all have opioid receptors in our brain. And when patients use opioids, the opioids attach to the opioid receptors. And over time, patients like the feeling of opioids on the receptor. And unfortunately, after a while, it takes more and more and more opioids to get that feeling. And that's how our patients develop tolerance. If the opioids are not on the receptor, they have withdrawal, and that is extremely painful and uncomfortable, which is why they seek more opioids. What buprenorphine does is that because it's a partial agonist, it fits perfectly into that opioid receptor. And so it calms down the withdrawal effects. And I think another important point about buprenorphine is because it has such a high affinity for the opioid receptors, it's able to block other opioids from attaching to the receptor, which really is the mechanism by which it reduces overdose. So let's talk about a case. So Mr. C, 55-year-old, HIV with CD4, 180, viral load is detectable. I met him because he had been treated for hepatitis C 3 times and he had been infected 3 times. He has a history of bipolar disorder, and during our intake, he shared with me that he uses about $20 of heroin per day, but he didn't really think it was a problem. He worked in construction, and he, thought life was going okay. We had to discuss whether he was interested in substance use disorder treatment 3 times before he was like, you know what, like I, tried to not use and I couldn't do it. I got really sick. I am interested in treatment. One of the key points, I think, is helping patients to understand the difference between intoxication signs and withdrawal signs. And the reality is, I think our patients know a lot more about this than us. This is key because you really want patients to be in withdrawal before they initiate buprenorphine. And so the signs of withdrawal that most patients will have include restlessness, irritability, anxiety, insomnia, yawning, abdominal cramps, diarrhea or vomiting, dilated pupils, sweating, and piloerection. And most patients can tell you what their withdrawal signs are. It's critical because they need to be in withdrawal to successfully initiate buprenorphine. While, in the past, most buprenorphine initiations were done in the clinic, essentially all the buprenorphine initiations I've done in the last 3 years have been done by the patients by themselves at home. And the way we've done that is by providing information and then tools that the patient can
go
use.
Down and work with her on that.
So, for example, there are these sheets which are available in clinic and which we can share that walks patients through how to initiate buprenorphine. So patients definitely have to be in withdrawal before they start use. They are limited to not taking more than 12 milligrams on the first day. They are instructed to keep the medication under their tongue until it fully dissolves. They should not eat, drink, or swallow while it is dissolving. And then they take their first dose. Now that first dose needs to be a small dose. And usually I ask patients to cut an 8 milligram film into 4 pieces and have the first dose under their tongue until it dissolves. Wait for 1 to 3 hours. If they continue to have symptoms of withdrawal, put another film under their tongue, wait another 1 to 3 hours. If they continue to have symptoms of withdrawal, put another film. So remember we started with an 8 milligram film, which we have cut into 4. So each film is just 2 milligrams with the instruction not to take more than 12 milligrams on the first day. So for Mr. C, I wrote a prescription for buprenorphine. I always start with the 1-week prescription, dosed at 4 milligrams, because we know that's the optimal dose for most patients. So which is 14 films of 8 milligrams. I got permission to refer him to Restore, and so gave him the number for the Restore pair and asked the Restore pair to reach out to him. He was offered weekly virtual groups, but declined. We continued weekly prescriptions for 4 weeks and then switched him to a monthly prescription of buprenorphine. And with each prescription, we got urine toxicology. And so some points about urine toxicology. Now, the presence of substances in the urine toxicology is not a reason to discontinue treatment for opioid use disorders. It's akin to stopping diabetes treatment because the patient is eating cookies. But we do need to look for buprenorphine metabolites in the urine because that's an indication that the patient is actually taking the buprenorphine. And if, however, the patient consistently does not have buprenorphine metabolites in their urine, then they're not taking it, and so it can't help. And so in those cases, I stop prescribing buprenorphine. Other points about buprenorphine, there's no recommended time limit for treatment, so patients can remain on treatment for years. And in addition, the requirements for the X waiver has changed. Now, the HHI's guidance now permits practitioners with a DAA to apply for an X waiver to treat up to 30 patients without completing the training course or attesting to provision of psychosocial treatment or counseling. There are other options. There are long-acting options of buprenorphine available as an injection every 28 days. There's also an implant available as 4 implants every 6 months. There's also the option for naltrexone, which is available as extended release naltrexone, given as an injection once every 21 to 28 days. It's indicated for prevention of relapse to opioid dependence. However, patients need to be completely off opioids for 7 to 10 days before they can get their first injection. The data for injectable naltrexone for opioid overdose is not as good. There's no good data for reduction in mortality, but I will say that extended release naltrexone is also indicated for treatment of alcohol dependence. As we think about alcohol, it's important that as providers, we remember what a standard drink is, so that when our patients say to us, I have a 1/5 of liquor every other day, we understand that that's 17 standard drinks. And when we think about risk stratifying alcohol use, the NIAAA definition of hazardous or risky alcohol use is greater than 4 drinks on a single day for men or greater than 14 drinks per week for men. Amongst women, is greater than 3 drinks on a single day or greater than 7 drinks per week. And we also need to remember, even below this limit, some patients can have problems, patients who have liver disease, patients who are pregnant or have a history of alcohol use disorders. And so I'm going to switch quickly to Mr. C, who is a 28-year-old man who has HIV, hepatitis C, severe asthma. He's drinking a pint of vodka daily, reports a history of blackouts, daily marijuana, has a dog, but is otherwise socially isolated. His exam is significant for clubbing, gingivitis. You see on his labs that his CD4 is 6, viral load is 54,000. He has hepatitis C viremia. Look at his liver numbers, AST 52, ALT 25, platelets 125, INR and bilirubin are elevated. I mean, this is a very sick gentleman. And so I'm going to ask folks to quickly put notes in the chat, what they would do for this patient. Would you refer to hospice because there's nothing else you can do for this gentleman with a CD4 count of 6? Would you explore his goals for his health? Would you explore potential options for alcohol use disorder treatment? Would you refer to psychiatry? Or would you consider a combination of B, C, and D? Any takers?
Hi, Shaun.
Yes.
I would do B, C, and also explore psychiatry with him.
Thank you, Joyce. And I cannot agree more. And that's exactly what happened with this patient. We did all 3. Very quickly, I'm going to review the data for an additional intervention that was started with these patients, injectable naltrexone. This is data looking at patients who were discharged from detox for alcohol, comparing 2 different doses of injectable naltrexone at 380 and 190 to patients who got placebo, and the outcome was proportion remaining abstinent. And you see that patients that got the higher dose of naltrexone had a significantly higher likelihood of remaining abstinent than patients that did not. The plot to your right shows data amongst HIV-infected patients who were released from incarceration that got an injection of naltrexone before they were released, and looks at viral proportion with viral suppression. You see at baseline rates of viral suppression in those that got placebo, and viral suppression in those that got naltrexone. And the key point is that viral suppression rates were significantly higher in those that got injectable naltrexone at 56.7 compared to those that got placebo. And so for Mr. C, he identified his biggest goal as getting surgery for his anal condylomata. And he said, unfortunately, the doctor says he will not do the surgery because my liver is so sick. His primary goal is to get his anal condylomata addressed. And so that fits in nicely with addressing his alcohol use to meet that primary goal. And so he agreed to go into medically supervised alcohol detoxification. He was linked to peer recovery services. He was prescribed oral naltrexone as a bridge to extended release naltrexone. And the plan was him to get his naltrexone every 28 days. And 60 days later, he had engaged with psychiatry. He started a job. His alcohol use had dropped from a pint to a quarter of a pint, but that's a significant improvement. He was taking his antiretroviral therapy. His liver numbers miraculously improved. I think that's the power of youth. And he has continued to receive his injectable naltrexone. Now he's getting it every 21 days, but he remains engaged in care, and he's going to get his surgery, and hopefully he will continue to do well. I'm going to switch gears and talk a little bit about Restore, because Restore supported some of the infrastructure that helped that patient. The goals of Restore were to increase screening and treatment for substance use disorders, support providers to be able to do this as part of their care, and provide ongoing psychosocial support for our patients. And we also worked really hard to build collaborations with substance use disorder treatment programs in the community so that patients could be quickly linked into ongoing care. Between April 2019 and August 2021, we provided care to 144 patients. I will say that we had over 300 referrals, but these were the 144 that actually engaged in care. You see that the median age is 52, 35% were women, predominantly African American. And I think also really important that 53% had high school education, 12% were homeless, 30% had a partner or were married, rates of employment were low, so that this is a population that I think has ongoing needs for social support and case management. 74% were HIV infected. And these are 3 and 6 month outcomes. We see that illegal opioid use in the past 30 days, 35% reduction in illegal opioids, 42% reduction in heroin, 38% reduction in fentanyl, 55% reduction in harmful alcohol use when you compare 6 months to baseline. I think also very exciting is the improvement in mental health. We had a 60% reduction in symptoms of anxiety as measured by the GAD-7. Not as good with major depression with only a 16% reduction, but look at hospitalization and ED visits. 57% reduction in inpatient hospitalization, 65% reduction in ED visits. And so this leads us to think that maybe we can positively impact both substance use disorder and mental health disorder through interventions that include a team-based approach. And I'm so excited to work with this phenomenal group of people who you see here, who meet every week to discuss our patients in our combined substance use disorder treatment programs. It's a team-based approach to care, weekly clinical meetings in which the patients are presented by the peers or our addiction counselor and the treatment plan discussed. It integrates substance use disorder and mental health disorder. And when we put all this together and we think about our goal of ending the HIV epidemic, we're going to need to improve HIV outcomes for all groups, including people with HIV who use substances. And so we need implementation strategies that integrate mental health and substance use disorder screening and treatment into HIV care settings. Prior to the implementation of Restore, a survey had gone out, and thanks to many of you on this call that took that survey. Now, we know that majority of the providers at Bartlett screen for substance use disorders. Our medical assistants also administer a PHQ-2 screen. And when a substance use disorder is identified, 3 of 5 providers refer to co-located substance use or mental health disorder services. In a chart review that was done of 153 patients in for HIV care, majority, 58% screened positive on the PHQ-2, 25% were referred to psychiatry, and I can imagine why that number is low. I have had multiple discussions with my patients where I have said, I'd really like to refer you to psychiatry, and the response is no. No, no, no. I do not need to see a psychiatrist because of the stigma associated with mental health disorders. And even when patients are referred to psychiatry, the no-show rate for new intake psychiatry appointments is 90%. And so although we're trying really hard, we are not successfully connecting our patients to the care they need. And that was the rationale for an R01 that was recently funded by NIDA. It's a type 1 implementation effectiveness trial of an adapted collaborative care model with peer specialists as care managers. It's looking at the evidence-based intervention, which is collaborative care, and we're assessing our outcomes using the implementation science frameworks of the AIM and normalization process theory. And so what is collaborative care? Believe it or not, it's an evidence-based model of integrated mental health and substance use care, which is endorsed by the American Psychiatric Association. There are over 300 papers looking at collaborative care, and it has been evidence-based for over 30 years. It's been demonstrated in clinical trials to have significant effectiveness for treatment of depression and anxiety in primary care settings. And the core components is that you have a team of multidisciplinary providers, including the primary physician, a care manager, and a consulting psychiatrist. There's a population focus with the team working together to provide care and continuously measure and track health outcomes of the patients that are being managed by the team. It's measurement guided using tools like the PHQ-9, scoring them over time and shooting for goals such as a 50% reduction in PHQ-9 scores over time, for example, and the use of evidence-based practices with the team adapting scientifically proven treatments like buprenorphine for substance use disorders or antidepressants for depression within an individual clinical context to achieve improved health outcomes. And so this is what we're proposing for the peer-supported collaborative care model. So you have the patient in the middle who has their HIV care provider, who is doing everything in their power to improve outcomes, including HIV, mental health, and substance use disorders. We also have a peer care manager who may in some ways be able to interact with the patient in culturally appropriate ways that might increase the likelihood of the patient being willing to take up mental health and substance use disorder treatment. And so the peer care manager is really working with the patient to motivate adherence to appointments and use of treatments, provide brief supports, and then facilitate community supports that may be required. The peer care manager also conducts monthly surveys, the PHQ-9 and the GAD-7. These monthly surveys are presented to the consultant psychiatrist using a registry, which is a tool that can track progress of patients over time. And in this weekly case supervision, the consultant psychiatrist reviews the patient scores, recommends treatments, and sets goals for the patient. For example, in 6 months, we would like Mr. C to have a 50% reduction in his PHQ-9, and this is how we will achieve this. The consultant psychiatrist then communicates this to the HIV provider by putting a note in the EMR to the provider and his nurse so that they know this is what's going on with Mr. C. He has features consistent with depression. I would consider starting him on a 20 milligram dose of an antidepressant. And the primary care provider has the choice to take up the recommendation or not. The implementation strategies that we're using are patient engagement, where the case manager is working closely with the patient by weekly interaction initially to try to engage them in care. Interactive assistance, where there's access to a consultant psychiatrist with experience providing HIV and providing substance use disorder and mental health disorder care to patients with HIV, providing recommendations to the HIV provider and the opportunity for the HIV provider to ask the psychiatrist questions. Ongoing consultation consultation from the consultant addiction psychiatrist, and then clinician support for patients' engagement and ancillary social support by the peer case manager. And so I've spoken to some of you on this call, and I am interested in feedback from others on this approach. We are working to implement routine screening at least annually with a PHQ-2 or a GAD-2 or a NIDA quick screen. The goal would be to try to implement this as something the patients can complete by themselves. For patients that screen positive, the HIV provider would get an electronic alert of a positive screen. These individuals would be eligible for informed consent. And if patients decline consent, that's fine. Patients will be randomized to 2 arms, collaborative care versus usual care. For individuals assigned to the collaborative care arm, they would be assigned a trained peer care manager who would complete monthly PHQ-9 and GAD-7 with them. This will be stored in a registry. The registry would be reviewed weekly by the addiction psychiatrist with the peer care manager. Treatment recommendations by the consulting addiction psychiatrist would be communicated through the EMR to the HIV provider and the nurse, and the recommendation implemented by the HIV care provider with coordination by the care manager. We will assess outcomes at 12 months. The primary outcome is HIV virologic suppression, secondary outcomes, retention in HIV care, and uptake of mental health and substance use disorder treatment. These assessments will be done through a combination of quantitative surveys, qualitative interviews, and we'll also do a cost effectiveness assessment. Our peer care managers, I think, are very valuable. Their lived experience, I think, makes them very credible to our patients and increases the likelihood that they will be willing to accept the supports being provided. The peer care managers will work under clear guidelines, define training, and will have well-established support and supervision. They are being trained in skills, motivational interviewing, goal setting, perspectives of psychiatry for peer coaches. There will be competency assessments, refreshers, and a routine protocol for providing care. And so I know this is a lot that I have gone through. The goal, again, is to develop strategies that help providers make it easier to provide the care that they so want to provide for patients to improve outcomes. And so I have a couple of questions up here that I'd like us to briefly discuss. I'd love any feedback on this implementation strategy that I have shared. Do we think this is feasible for clinic workflow? Do providers think they would be interested in recommendations from addiction psychiatrists? And I will share that I'm very excited to have Jess Shu working on this project. As you know, he has so much experience with our patient population. Is this a good fit for our clinical setting? Do we think it's suitable for our patient's clinical context? And do we think it's a good match for our patient's needs? I'm going to stop sharing, and I'm hoping that folks will please give me some feedback and input.